Good day, future doctors. For today, I'm going to discuss about viral exanthems. I am Dr. Joan A. De Castro. The objectives of my presentation are to accurately diagnose diseases caused by viruses based on presenting signs and symptoms given various clinical scenarios, and to initially manage a child with viral exanthems. Human herpes virus 6b is responsible for the majority of cases of Roseola or exanthem subitum or sixth disease. A small percentage of children with Roseola have primary infection with human herpes virus 7. Roseola is an acute self-limited disease and occurs in children less than 2 years of age. The peak age is between 6 to 9 months, with infections occurring sporadically and without seasonal predilection or contact with other ill individuals. Majority acquire the infection from saliva or respiratory droplets of symptomatic adults or older children. Infants with Roseola present with an abrupt onset of high-grade fever, which is the most consistent finding with associated fussiness. Fever resolves after 3 days and gradually fade over a day, coincident with the appearance of a faint pink or rose-colored non-pruritic 2 to 3 mm morbilliform rash on the trunk. The rash usually lasts 1 to 3 days but is often described as evanescent and may be visible only for hours, spreading from the trunk to the face and extremities. Because the rash is variable in appearance, location, and duration, it is not distinctive. Associated signs are few but can include mild injection of the pharynx, palpebral conjunctiva, or tympanic membranes and enlarged suboccipital nodes. In Asian countries, ulcers at the uvulo-palatoglossal junction, called your Nagayama spots, are commonly reported. A history of 3 days of high fever in an otherwise non-toxic infant with a blanching maculopapular rash on the trunk suggests a diagnosis of Roseola. Supportive care is usually all that is needed for infants with Roseola. Parents should be advised to maintain hydration and may use antipyretics if the child is especially uncomfortable with the fever. Specific antiviral therapy is not recommended. Rubella or German measles or 3-day measles. Many cases of postnatal rubella are subclinical. Transmission is primarily through direct or droplet contact from nasopharyngeal secretions. The average incubation period is 17 days with a range of 12 to 23 days. They are most contagious when the rash is erupting, but can be contagious from 7 days before to 7 days after the rash appears. Clinical disease is usually mild and characterized by a generalized erythematous maculopapular rash, lymphadenopathy, and slight fever. The rash starts on the face, becomes generalized in 24 hours, and lasts a median of 3 days. Lymphadenopathy, which may precede the rash, often involves the posterior auricular or suboccipital lymph nodes, can be generalized, and lasts between 5 and 8 days. At the time of the rash, palatal enanthems have been noted and can be described as tiny, rose-colored lesions or petechial hemorrhage on the soft palate, also known as Forsheimer spots. In infants and children, they usually present with mild exanthematous disease. However, in adults, rubella is more severe and associated with more complications like transient polyarthralgia and polyarthritis, especially in females. The major clinical significance are transplacental transfer and fetal damage occurring as part of congenital rubella syndrome. Maternal rubella during first trimester of pregnancy can result in miscarriage, fetal death, or as constellation of congenital anomalies known as your congenital rubella syndrome. The most commonly described anomalies or manifestations associated with congenital rubella syndrome are congenital heart disease like PDA, ophthalmologic defects like cataracts, and sensory neural hearing impairment. CRS is usually associated with failure to thrive, developmental delay, and microcephaly. This is a triad of CRS: cataracts, heart defects, and hearing impairment. Detection of rubella-specific IgM antibody usually indicates recent postnatal or congenital infection in a newborn infant, but false positive and false negative results occur. Most postnatal cases are IgM positive by 5 days after symptom onset, and most congenital cases are IgM positive at birth to 3 months of age. Only supportive treatment of rubella is recommended. Measles is one of the most contagious of all infectious diseases. 90% of exposed susceptible individuals experience measles. The virus is transmitted by direct contact with infectious droplets or by airborne spread when an infected person breathes, coughs, or sneezes. Measles can remain infectious in the air for up to 2 hours after an infected person leaves an area. They are infectious 3 days before to 4 to 6 days after onset of rash. Measles is characterized by a prodrome of fever and malaise, the 3 C's: cough, colds, and conjunctivitis, a pathognomonic enanthema called your Koplik spots, followed by a maculopapular rash. The rash begins on the forehead, behind the ears, and on the upper neck as a red maculopapular eruption. It then spreads downward to the torso and extremities, reaching the palm and the soles. The exanthema frequently becomes confluent on the face and upper trunk. These are pictures of full-blown measles. With the onset of the rash, the symptoms begin to subside. The rash fades over about 7 days in the same progression as it evolved, often leaving a fine desquamation of skin in its wake. Of the major symptoms of measles, the cough lasts the longest, often up to 10 days. Healthcare providers should consider measles in patients presenting with febrile rash illness and clinically compatible measles symptoms. No specific antiviral therapy is available. The WHO currently recommends vitamin A for all children with acute measles regardless of their country of residence. It is administered once daily for 2 days. Next is varicella zoster virus infections. Varicella is highly contagious. The virus can be spread from person to person by direct contact, inhalation of aerosols from vesicular fluid of skin lesions of acute varicella or zoster, and possibly through infected respiratory secretions that may be aerosolized. The incubation period of varicella is 14 to 16 days after exposure to a varicella or a herpes zoster rash, with a range of 10 to 21 days. A person with varicella is contagious from 1 to 2 days before rash onset until the lesions have crusted. In healthy children, varicella is generally mild. The lesions first appear on the scalp, face, and trunk. The initial exanthem is intensely pruritic, and they present as erythematous macules, becoming papular, then developing into clear fluid-filled vesicles, leading to clouding and umbilication of lesions in 24 to 48 hours. While initial lesions are crusting, new crops form on the trunk and then extremities. It is important to note that simultaneous presence of lesions in various stages of evolution is characteristic. Distribution of the lesions in chickenpox is central or centripetal. Ulcerative lesions can be seen on the mucosa of oropharynx and vagina. In children, the eyelids and conjunctivae can be affected. The average number of lesions is about 300. In healthy children, the lesion ranges from less than 10 to more than 1,500. For children vaccinated with varicella vaccine and still develops varicella, it is called breakthrough varicella. They are usually vaccinated more than 42 days before the rash. It is caused by wild-type varicella and is usually mild, but just the same, still contagious. They typically are afebrile or have low fever and develop fewer than 50 skin lesions. They usually have a shorter illness compared to unvaccinated people who get varicella. The rash is more likely to be predominantly maculopapular rather than vesicular. Herpes zoster, also known as zoster and shingles, is caused by reactivation of the varicella zoster virus, the same virus that causes varicella. They manifest as vesicular lesions clustered within one or less commonly two adjacent dermatomes or your localized dermatomes. The rash is usually painful, itchy, or tingly. These symptoms may precede rash onset by days to weeks. The rash develops into clusters of vesicles. New vesicles continue to form over 3 to 5 days and progressively dry and crust over. They usually heal in 2 to 4 weeks. There may be permanent pigmentation changes and scarring on the skin. The most important complication is post-herpetic neuralgia. A closer look at the zoster where the rash develops into clusters or vesicles. Varicella should be considered for patients presenting with successive crops over several days with lesions present in several stages of development. The decision to use antiviral therapy and the route and duration of therapy should be determined by specific host factors, extent of infection, and initial response to therapy. Antiviral drugs have a limited window of opportunity to affect the outcome of VCV infection. In immunocompetent host, most virus has stopped by 72 hours after onset of rash. The duration of replication may be extended in immunocompromised host. The only drug available for treatment of varicella for pediatric use is acyclovir. Oral acyclovir is not recommended routinely for treatment of uncomplicated varicella in the otherwise healthy child because of its marginal benefit, the cost of the drug, and the low risk for complications of varicella. It should be considered for otherwise healthy people at increased risk of moderate to severe varicella. Herpes simplex are ubiquitous and there are no seasonal variations in risk for infection. The mode of transmission is direct contact between mucocutaneous surfaces. The hallmark of herpes simplex virus infections are skin vesicles and shallow ulcers. Herpes gingivostomatitis may often affect children 6 months to 5 years of age but is seen across the age spectrum. It is an extremely painful condition with sudden onset, pain in the mouth, drooling, refusal to eat or drink, and have high-grade fever. The gums are markedly swollen and vesicles may develop throughout the oral cavity. Tender submandibular, submaxillary, and cervical lymphadenopathy is common. The breath may be foul. Untreated, the illness resolves in 7 to 14 days. Herpes labialis is commonly known as fever blisters or cold sores, which is the most common manifestation of recurrent HSV-1 infections. The most common site is the vermilion border of the lip. In older patients, they complain of burning, tingling, itching, or pain 3 to 6 hours before development of the herpes lesion. Generally, it begins as a small grouping of erythematous papules that over a few hours progress to create a small thin-walled vesicle. The vesicles may form shallow ulcers or become pustular. The short-lived ulcer dries and develops a crusted scab. Complete healing without scarring occurs with epithelialization of the ulcerated skin, usually within 6 to 10 days. Herpetic whitlow is a term generally applied to HSV infection of fingers and toes, although, generally speaking, it refers to HSV infection of the paronychia. Among children, this condition is most commonly seen in infants and toddlers who suck their thumbs. It is caused by HSV-1, and in adolescents with exposure to genital secretions, it is caused by HSV-2. It starts with itching, pain, and erythema 2 to 7 days after exposure. The cuticle becomes erythematous and tender and may appear to contain pus. The lesions and associated pain persist for 10 days, followed by rapid improvement and complete recovery in 18 to 20 days. Recurrent herpetic whitlows are often as painful as the primary infection but shorter in duration. Hand-foot-mouth disease is one of the more distinctive rash syndromes and is most frequently caused by Coxsackie A16 or enterovirus 71 in large outbreaks. They are found in an infected person's nose and throat secretions such as saliva, sputum, or nasal mucus, blister fluid, and feces. Transmission is primarily spread person to person via exposure to close personal contact, such as hugging an infected person, the air when an infected person coughs or sneezes, contact with feces like changing diapers of an infected person, then touching your eyes, nose, or mouth before washing hands, and contact with contaminated objects and surfaces like touching a doorknob that has viruses on it, then touching your eyes, mouth, or nose before washing your hands. It is also possible to get infected if you swallow recreational water, such as swimming pools. However, this is not very common. This is more likely to happen if the water is not properly treated with chlorine and becomes contaminated with feces from a person who has HFMD. Generally, they are most contagious during the first week of illness and sometimes days to weeks after symptoms go away. It is usually a mild illness with or without low-grade fever. The oropharynx is inflamed and contains scattered vesicles on the tongue, buccal mucosa, posterior pharynx, palate, gingiva, and/or lips. These may ulcerate, leaving shallow lesions with surrounding erythema. Maculopapular, vesicular, and/or pustular lesions may occur on the hands and fingers, feet and buttocks, and groin. The hands are more involved than the feet. Lesions on the hand and feet are usually tender, 3 to 7 millimeter vesicles that occur more commonly on the dorsal surface but frequently also on palms and soles. Vesicles resolve in 1 week. Buttock lesions do not usually progress to vesiculation. Healthcare providers can usually identify mouth sores caused by HFMD by considering how old the patient is, what symptoms the patient has, and how the rash and mouth sores look. A healthcare professional may sometimes collect samples from the patient's throat or feces. In the absence of a proven antiviral agent for enterovirus infections, supportive care is the mainstay of treatment. In summary, I have presented to you Roseola, exanthem subitum, or your sixth disease, Rubella, or your 3-day measles, Rubeola, or measles, varicella or chickenpox, zoster or shingles, herpetic gingivostomatitis, herpes labialis, herpetic whitlow, and hand, foot, and mouth disease. Thank you.